Welcome to this Step 3 review on abdominal pain in the emergency department test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for abdominal pain and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the surgery and emergency medicine sections of your core review book and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for abdominal pain in the emergency department. Second, we will apply specific strategies for choosing between ultrasound and computed tomography, timing the surgical consultation and stabilizing gastrointestinal bleeding. And third, we will master the next best step question format for appendicitis, cholecystitis, and diverticulitis. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach. Our first strategy is the ultrasound versus computed tomography split. When you see an abdominal pain question, immediately ask yourself which imaging study the STEM is steering you toward. Choose ultrasound first when you see right upper quadrant pain, suspected gallbladder disease, a pregnant patient, or a child. Ultrasound is first line for gallstones and cholecystitis, and it avoids radiation. Choose computed tomography of the abdomen and pelvis first for a stable non-pregnant adult with right lower quadrant pain, left lower quadrant pain, or a vague unclear source. That is your go-to for appendicitis and diverticulitis. The boards love testing this split, so make the imaging question your first mental move. Strategy 2 is all about timing the surgical consultation because the boards love to test whether you call surgery now or image first. Consult surgery immediately when you see peritoneal signs such as rigidity, rebound tenderness and guarding, or when you see free air under the diaphragm or hemodynamic instability. A rigid, board-like abdomen is a surgical abdomen, and calling surgery is the next best step. Image first, then consult when the patient is stable with localized tenderness and no peritoneal signs. In that case, confirm the diagnosis with imaging before involving surgery. The key is reading the STEM for stability and peritoneal signs. Now let us go through high-yield STEM recognition. For appendicitis, the classic STEM is periumbilical pain that migrates to the right lower quadrant with anorexia, low-grade fever, and tenderness at McBurney point. Confirm with computed tomography in adults and ultrasound in children and pregnancy, then proceed to appendectomy. For cholecystitis, look for right upper quadrant pain after a fatty meal, fever, and a positive Murphy sign, confirmed by ultrasound, then treat with antibiotics and cholecystectomy. For diverticulitis, look for left lower quadrant pain, fever, and altered bowel habits in an older adult, confirmed by computed tomography, then treat uncomplicated cases with antibiotics and bowel rest. These 3 stems repeat over and over on practice questions and on the real exam. Let us work through our first practice question. A 24-year-old man presents with 1 day of pain that began around the navel and moved to the right lower quadrant. He has nausea, anorexia, and a fever. He has tenderness at McBurney point without rigidity, and he is hemodynamically stable. What is the most appropriate next step in management? Take a moment to think about this before we walk through the answer on the next slide. Let us break this down step by step. Step 1, spot the pattern. Migratory pain, anorexia, fever, and tenderness at McBurney point. This is classic appendicitis, and the patient is stable, which is the detail that drives the answer. Step 2, apply the rule. In a stable adult with suspected appendicitis, you confirm the diagnosis with computed tomography of the abdomen and pelvis before going to the operating room. Imaging precedes surgery when the patient is stable. Step 3, eliminate wrong answers. Taking the patient straight to the operating room skips confirmation in a stable patient. Right upper quadrant ultrasound is for the gallbladder, not the appendix in an adult. Discharging home ignores a likely surgical diagnosis. The correct answer is B, obtain a computed tomography scan of the abdomen and pelvis. Here is our second practice question. A 30-year-old woman who is 20 weeks pregnant presents with several hours of right upper quadrant pain after a fatty meal, along with nausea and a low-grade fever. She has a positive Murphy sign and is hemodynamically stable. What is the most appropriate initial imaging study? Think through this one carefully. The key detail here is that she is pregnant. We will walk through the answer next. Let us work through this answer. First, read the question carefully. This describes classic cholecystitis, right upper quadrant pain after a fatty meal with a positive Murphy sign. The detail that drives the answer is that she is pregnant, so you must avoid radiation. Now, why does ultrasound win? Ultrasound is first line for gallbladder disease and uses no radiation, which makes it ideal in pregnancy. Computed tomography and plain films expose the fetus to radiation, so they are wrong here. Magnetic resonance imaging is a reasonable second-line study, but is not the initial choice. The correct answer is B, right upper quadrant ultrasound. Let us review management rules for the boards, because this comes up constantly. For surgical conditions, appendicitis is managed with appendectomy. Acute cholecystitis is managed with antibiotics followed by cholecystectomy, usually during the same admission. Complicated diverticulitis with a large abscess, perforation, or obstruction also requires surgical management. For medical conditions, uncomplicated diverticulitis is managed with antibiotics and bowel rest, and a small pericholecystic abscess may first be drained before surgery. The high-yield pattern is simple. The boards want you to choose medical management for the stable, uncomplicated patient and surgery for the unstable or complicated patient. Read the stem for stability and complications, and the management choice will follow. Here is our third practice question. A 60-year-old man presents with several episodes of vomiting bright red blood. His blood pressure is 80/50 and his heart rate is 120. He is pale and diaphoretic. What is the most appropriate next step in management? This is a classic stabilization question. Look closely at the vital signs and think about what they are telling you before you reach for a diagnostic test. We will walk through it next. Let us break down this answer. The classic pattern here is an unstable patient with a low blood pressure and a high heart rate from active bleeding. Those vital signs tell you the patient is in shock, and stabilization always comes before any diagnostic test. Now the key distinction. Upper endoscopy and computed tomography are diagnostic steps, and they come after the patient is resuscitated, not before. Starting a proton pump inhibitor and observing ignores the shock entirely. Airway, breathing, and circulation come first. The correct answer is B, place 2 large-bore intravenous lines and give fluids. Here is a critical test-taking pearl. Stabilize before you investigate. When a stem gives you a low blood pressure and a high heart rate, the patient is unstable, and your first move is always resuscitation. That means 2 large-bore intravenous lines, fluids, a type and cross-match, and blood products when needed. Only after the patient is stable do you pursue endoscopy or imaging to find the source of bleeding. Here is why this matters on the exam. The boards love to tempt you with a diagnostic test as a distractor in an unstable patient. If the vital signs show shock, the answer is almost always stabilize first. Recognizing instability in the stem is the single most reliable shortcut on emergency questions, so train your eye to check the vital signs before anything else. That wraps up our review of abdominal pain in the emergency department test-taking strategies for Step 3. Remember to review the surgery and emergency medicine chapters in your core review book and your question bank. Focus on the imaging choices, surgical consultation timing, and gastrointestinal bleeding stabilization we covered today. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.